Chris, John, are you on the phone?
Yes, we're here, Ed.
Okay, well, let me make some introductions. Chris, John, this is the team. Team, this is Chris and John.
Very good.
So, just by way of introduction, Chris Fabian and John Johnson are the founders of the Center for Priority-Based Budgeting. Last week, when I was doing the workshop, they were flying up for our presentation at Human Services, but at the end of that presentation, we had the opportunity to introduce them to Chris and Jennifer. I think at that point in time, there was enough of a conversation to get a sense that the process that they have developed, given the timelines that we're looking for, makes sense. Recognizing that it is going to have to be adjusted because it was originally designed for a municipal government context, and this is a much bigger ministry with not as broad a base of portfolio, and that's part of the reason for going through this process today around the program inventory. Is how do we create enough of a sense of what these decision units are so that as we start to go through the evaluation, we start to get a sense of which ones are contributing to these outcomes that we've defined or not. So now, in terms of logistics, are you holding the clicker to say go to page 2, or? So it's just a question of saying, John, we're on page 2 of your slide presentation, or page 3, or page whatever. So
Okie doke.
what we're going to do, we're going to take no more than about 15 minutes. John and Chris are going to walk through this concept of we're now on step 3. We now need to do this program inventory. What are some of the questions we need to ask to start understanding this notion of a decision unit? And the reason we use that is we're trying to come up with something that's not program, because the word program is being used in many different contexts right now. We've got these clusters, we've got programs within a ministry that may mean something different than the programs the Treasury Board is referring to. So we're trying to come up with a different term that's at a greater level of granularity than, primary care networks, where there's a $1.4 billion spend, and you go, are we getting good value for that? Well, we got to get a little deeper than that to know the answer to that question. What's that appropriate level of detail? And that's what we're going to use John and Chris to help us walk through a couple of examples of how we would go through and answer that question, so that as we start to look at this program inventory, we've got a little better granularity in terms of the types of programs or decision units we're evaluating. Okay? Does that make sense? Again, I'm going to have them online. We want to make the presentation piece very short, and then actually get into a conversation around, let's take an example and see how that might work. So, okay, without further ado. So John, Megan's got the mouse, so if you just say go to slide 2 or slide 3, we've got the presentation up on the smart board in front of us, and it's basically the title page. So over to you.
Very good. And again, we appreciate this opportunity to work with all of you. This is John speaking right now, and Chris will be joining in just real quickly. I think that you'll find that what we are proposing is a pretty logical, simple process, and this particular step is really critical to the successful evaluation of what you do against the results that we're working on to determine. You've already done a great job in that. Most organizations that Chris and I work with, they're really starting from scratch with nothing. And we think you've got just a great beginning. But our work today is to really help encourage you to break these areas that I think you're calling more program-oriented into something, as Ed said, that for now we're calling decision units, whatever that descriptor is, that make for a more manageable discussion and get into a little more detail so that as we're evaluating things, the conversation becomes richer. If we've got a budget the size of yours and we limit it to only 6 programs, we're not going to have the level of conversation that really needs to occur in terms of how are we achieving our results. It becomes way, way too much. And so our job is to help break those programs down into something that's more of a discussion unit that can really lead us to some better conversations. And so what we want to do is just give kind of a quick orientation. We'll try to know that we're talking about program inventories. That's the way our terminology works, but be very conscious of the fact that what we're trying to achieve is this decision unit level that will lead you to the right conversations and be able to demonstrate how you can influence those decision makers about the choices that have to be made so that your resources are going to the things that are your highest priorities, and you're looking at ways to not devote resources to the things that might not be as relevant to achieving the results that the Ministry of Health is trying to achieve.
If you want to go to slide 2, Megan, we won't belabor this. It sounds like you guys have covered the big picture, but in the overall methodology, this is where we are. We have this process of breaking down programs into these further discrete decision units. If you want to advance to slide 3, the overall philosophy, as John was starting to cover, is pretty simple. When we talk about a decision unit, this is what we're trying to get to. It's got to be defined at the right level. As John was describing, we've seen when programs or decision units are defined too large, they actually contain too many things. And where that's problematic in the process is that when you're evaluating that program or decision unit in terms of its influence on the outcomes you're trying to achieve, you'll find that, well, part of this program achieves the outcome, but part of it doesn't. And so how do you reconcile that? And you end up with a false evaluation of your programs overall. Whereas conversely, on the other side of the scale, if they're too small, if you identify checking email or emptying the trash as a fictitious program or decision unit that's too small, the problem with that is, okay, let's imagine we eliminated that program altogether. It would make no budgetary impact. It's too tiny. And so those are the ends of the spectrum. And that's what we're trying to focus in on. Where is it in the middle that helps us define what is just right? So if you want to go to slide 4, as we talk about this concept of decision unit, we realize that all the way down to where you see programs, that appears to be where you are today, that you have this concept of some large level of operation. What we're talking about in terms of decision units is actually smaller than the program level. Where we're going to be your coaches and guides along the way is to help make sure that you don't actually get too small and get down to that task or activity or line item level where that's not a decision unit either. You can't make a decision about that. So just to give you this overall sense of hierarchy, that's where a decision unit falls into the equation. So at this point, if you want to turn to slide 5, I'm going to turn it back to John, and we're actually going to lead you through the coaching that we lead organizations through to help answer the question, help walk around this, how do you get to the right level?
One of the things always to keep in mind is not only is this a helpful exercise as you're going about the implementation of a results-based budgeting approach to help your own ministry make decisions, but by being clear about the types of things that you do, the services you offer, those decision units. This serves as a great education tool for people outside your own ministry, or even perhaps at some of the staffing levels of the ministry where they're not familiar with everything the Ministry of Health does. It also helps the provincial officials to really understand What is it? What's the wide gamut of things that you do? You don't just do two things. You do lots and lots of things. And this is an educational tool as well, so that not only can you communicate internally, but externally to other ministries, to the provincial officials, or even to the community, to the citizens, so they have a better understanding that you're not just offering primary health services. What's entailed in all that? There's a lot to what is included. And just reviewing your website real quickly, I can see that already I can identify lots of significant things that will be important to articulate that this is different from this particular decision unit, so that we're helping to isolate some of those differences. So let's go through this particular exercise. And this isn't meant that you have to ask this question for everything you do. This is just meant to be a way to start thinking, how would we differentiate or break down some of the programs into these decision units? One of the areas that we find so helpful, whether it's in municipal government, in county government, or in state or provincial entities, who are you doing the activity for? Is there a specific group of people, demographic population, that are benefiting from the service? And by that I mean you could separate it into what are the things that we do that are targeted for our perhaps senior population, or our the children in our community, or perhaps even prenatal care, women's health issues, people with disabilities, whether those be physical disabilities or mental disabilities. Those are a different population, and that's a different service that we're offering. Even though it might be seems similar when we're looking at a program level, it's important to articulate the populations that we're serving. Are we dealing with a homeless population? Those that are economically disadvantaged. A rural population versus an urban population. Are there specific things we do that are targeting our rural areas, our rural population, as opposed to our urban population? Is there programs or decision units that are targeted specifically to an at-risk population? Something that is at risk for a specific disease? That may be a way to differentiate. Or is this simply something that we're targeting our healthy population? People that are physically fit, but we're trying to work our magic to keep them in that particular area. So I think you can see just from the examples, the who we're giving it for gives a wide differentiation of the types of things we're doing. So when we're talking about health benefits, identifying the large groups that we're offering this to may be a differentiation in terms of achieving the results based on how we've defined them. Where you're offering the services may also be a way to consider how to break these things down. Is there a specific area, a location, an environment that you're providing these? And just some examples, is this service being provided, is this decision unit offered at a hospital? Or is it at a clinic? Is it an emergency room? Is it at a school? Could it be an in-home service that we're bringing it to the particular demographic that we're serving? Are we doing this at a senior center, a preschool? Is it at a convalescence facility, a rehab facility? Again, the rural areas. Is this something that might differentiate one decision unit from another? So I think you can think about, where are we performing this? This is happening in, again, a pharmacy. Is that where this is happening? Is it happening in an exercise center? Those are the kind of things that you should question to say, would this differentiate the type of service we're doing? And even if you feel like it all might achieve the same result, as you do the evaluation, you might find that one of these areas becomes more important in the overall scheme of things in terms of relevance than another area, that perhaps the needs of the rural population are much more pronounced in some of the services and the results we're trying to achieve than folks in the urban area, that there's a higher emphasis on the healthy than the at-risk population. So think about who, think about where. Moving on to the next slide, number 6, thinking in terms of, and we're talking about big dollars here, but we want to break this down so that the dollars aren't so enormous that it also encompasses way more of the resources than we can articulate. If you've got a large program and you say, well, this one decision unit represents 90% of this program, and then we break the other 10% down into 3 or 4 units, that 90% is probably still too big. You want to get it down into a unit at a cost level or at an FTE level. What's the staff resources being divided? Now, obviously, in an organization the size of the Ministry of Health, if you're down to, well, we're going to try to identify one program for each person, each FTE we have, that's going to get down to the minutia that we don't want to get into. But obviously, if you're talking about we've got 1,000 employees doing this one particular service area, that still might be an area that we would say, can we break this down a little bit more? So one of the guidelines is think about the resources that you're devoting to this, whether that's the cost of this particular decision unit. And don't worry about being, well, we may not know what that is. You can get a good estimate based on what you think the number of FTE that are associated with delivering this particular decision unit and say, boy, that's going to be a pretty big area. Could we divide that down? Conversely, boy, we're only talking about a program that a decision unit that we think is only worth about $250,000. For your particular budget, that may be way too small. So use that as kind of a guideline. We also, in this area, talk about, are you using specialized resources? So when you're thinking about the FTE, think about what type of FTE do we need for this particular service? Is this something that we really need a physician, a nurse practitioner, a nurse, an optometrist, a pharmacist, a counselor, a therapist, administrative staff, maybe an inspector, a nutritionist? Think about any specialized FTE that are needed to provide that. That may also help you differentiate between one decision unit and another. If this has to be done by a physician, that's a higher level of service than something that you might be able to have a therapist or a nutritionist offer. This is another way of looking at a program and breaking it down by saying, if we've got specialized resources that we need to provide it, how do we separate that into a separate decision unit? That's another good way of breaking this down from one big group of what we would call decision units within a program to some areas that are manageable and can lead to some good discussions. Another area is, has someone else instructed the ministry that they have to do it? Is there a formal statute? Is there formal legislation? Is there something in a formally adopted policy? Is there something that is written and tells you that you have to offer this particular decision unit? That may be another thing. So read some of the legislative, some of the policies, some of the things that may articulate we have to provide this particular service. We have to do this. By calling it out specifically in written form at a policy level, at a legislative level, this tells you that it's worth recognizing this separately as a decision unit, even though it's rolled up into a larger program. We need to demonstrate that we recognize there is some legislative or written policy documentation that requires us to do it. Is there something that even in your particular area it calls for as a best practice, that there's a written recommendation from professional organizations in the health field area that say we need you to provide those kind of services, and that's why you're doing it? That could also help you differentiate, is this a standalone decision unit that we need to categorize? Moving on to slide 7, is there an end product? Is there something that people get, a tangible or maybe even an intangible, but still it's an end product that somebody could get? And some of the things that I was thinking about, do they get perhaps a prescription written for them? Do they get a filled prescription? Do they get some kind of medicine, some kind of treatment that they receive? Is there an inoculation? Is there an examination or a checkup? Is there just an assessment that is done? Do you get some kind of a permit? That may be something that some of your programs issue. Are you admitted to the hospital? That may be an end product. Is there a lab test that has to be done? Is there a release from treatment that says you are good to go? You are released from the rehab center. You are released from the convalescent center. These are the kind of things that when we talk about an end product, I think might be things for you to consider. Is there some certification? Is there some action that happens as a result of offering this particular decision unit for you? Thinking about just looking around you and saying, are there other providers outside of the Ministry of Health that do something similar? What we call this is the Yellow Pages test. Can you go into the Yellow Pages and see, well, somebody's doing something that we do. It's very similar. It's very close to the same thing. That would indicate that that's probably a standalone decision unit. There's somebody else offering it outside of the Ministry of Health or something that's very similar. Look at what you can see in your communities. Is there something that the one of your communities is offering that's very similar to what you in the Ministry of Health is offering? This is another way to start differentiating between things that could stand alone and be evaluated separately as we go through this further process of instituting a results-based budgeting approach. Do you advertise you do it? And this is sometimes I get kind of a snicker from folks, but go to your website, go to your phone directory, go to your organizational chart and see, are there titles? Are there website references? Is there a number you can call to get this particular type of service or treatment? If we're identifying it at that level in our advertising, in our phone directories, in our websites, in our promotional materials, in our marketing materials, again, think in terms of if we're saying we do this particular thing, that's probably a good indication that it should be a standalone decision unit because we're promoting the fact, we're advertising the fact, we're telling people we do this particular thing, this service that probably could then be a standalone area. Another thing that I didn't put on the slides, but as we were thinking in preparation for this, you might also think, especially in the terms of healthcare, what are we treating? Is that a differentiator? Are we looking at heart disease or cardiovascular problems versus obesity? Is it wellness versus illness? Is it preventative work versus actual treatment? Is it prenatal versus aging? Is it an immune deficiency versus a muscular issue or a musculoskeletal issue? It's thinking in terms of, would that help us better differentiate and articulate the wide gamut of services we offer so that within a program, we're being a little more specific about the reason for the treatment. And I think especially in looking at the website, you do things that are wellness versus things that are treatment of actual illnesses. Even breaking down some of the major areas of disease or concern that you're addressing certainly helps communicate, again, the wide gamut of things that the Ministry of Health offers, so that instead of saying primary care, we're really talking about primary care within these treatment areas, within this targeted population, by thinking about where we're doing it so that people know I can get this at home, I can get this at a nursing home, a convalescent center, I have to go to the hospital, or I can get this at a clinic. Again, I think you can see that these all don't apply to everything that you do, but it's a way to start breaking it down in your mind and asking the questions, does this make sense in terms of a way to break these out into decision units that we can evaluate against the results we're trying to achieve, as well as give us a flavor for the wide gamut of things that the Ministry of Health offers to both inform our own decisions about how we're going to use our resources, but also help communicate our story to those outside the Ministry of Health that are influencing our decisions, or educating the community on how broad a coverage that the Ministry of Health has in providing these services to the community.
Fantastic. If you go to slide 8, we do have a couple of wrap-up slides, and we'll turn it over. It's correct me if I'm wrong, but it sounds like, Jennifer, that you have a template under design that is going to be kind of the method to capture this information as participants go through and identify decision units. Is that correct?
I think the big question on the table is what we have defined as a program.
Oh, right. I'm sorry. I meant in terms of just a simple template to distribute as they go through the process and then actually land on the inventory. We have a template that we can distribute to you that will be helpful as everybody is coming to a conclusion, actually filling in the form, if you will.
Yeah, that's right. We need to some work on that. We can offline kind of make sure that it's going to fit.
Excellent. So we'll send that to you guys, but just for everyone in the room, the basic idea of this, it's not complicated. It's just as you go through those questions that John just led you through, you're going to come to a point where you've identified your decision units. And truthfully, when we work with organizations, they can get 80 to 85% of the way there following this initial orientation. You know what these things are, and the initial work, it'll be more intuitive than you might believe right now. It's those final ones that are going to take a little bit of finessing, and it's okay if you don't land on the perfect inventory. This is happening at a pretty good pace. The idea, though, is you'll get a template just for the process of completing this, where you can enter in your department or division, keep track of that hierarchy, and then identifying within the program area itself how you've broken up that program into various decision units, and then probably most importantly, entering in a description, and that it can be totally brief, just giving a basic sense so that anybody else looking at your decision units, which will happen later on in the evaluation process, will understand what it is that you're describing.
And what I would encourage is, sometimes we get afraid of, too much. It may be easier as you're free-forming and brainstorming. Don't be afraid to just list everything you think about, and then as you step back, it'll be easier to say, boy, it makes sense to combine these or roll these up. It's a lot easier in this brainstorming process in this particular area. List everything you can think of, and then it's so much easier to roll those up into manageable units. But don't be afraid of getting down into too much detail. We'll also help roll that up, and if that's the way your brainstorming can help you identify these things, it will be worthwhile rather than being afraid of getting too much detail. It's a lot easier to roll up as we're refining these inventories than to continually try to break them down. So don't be afraid, as Ed would say, of the pebbles. We can always put the pebbles back up into a larger period. So the brainstorming, just start listing, just start thinking about it. And then I think it'll be easier to determine how then we can refine this so that it's in a manageable unit, so that we can finalize these inventories to a level that will be workable, but yet worthwhile as we go through this effort.
John,
Yes.
I think we should pause for a second.
we're going to take a pause.
We've got the what. I think we're after we got a better clarity.
Jump to the what. Now we need to focus on the how. Yep.
Is the challenge is that when we look at our list of programs,
Yep.
we're trying to go now, but this is primary care. This is an organizational issue. It's much larger than that. So that's part of what I'm trying to unpack is learning a little bit more about the why. In our focus, how does that look? And how do we shape or see what we've got in the program?
Okay.
And so,
Yep.
I'm totally confused.
Okay.
a gazillion. So
Okay.
you have an area of hips, and you have an area that's
Yep.
hips in the community and hips in the hospital. I mean, it's huge. It's
Too big.
huge.
Okay.
So
So that,
my question was, is there a priority for this? Because in my mind, when I'm looking at least 3,000 services in our schedule, provided by numerous physicians
Yep.
on the side of the ditch and ICU, whatever,
Yep.
I'm going to go to the unit
Yep.
that says, has someone told me I have to do this? And I'm going to say, yep, Canada Health Act. So I am going to ignore the what, the when, the where, whatever.
Yep.
And I'm going to say Canada Health Act. All
so,
of them.
so this is now taking the concept and determining how we apply that to the reality of health. Okay, so this is now the leveling that we have to go through. So I wanted to walk through an example that is on your document that would allow you to at least see one way in which you could break it down. Now, I don't want to talk about primary care units, because that's primary care networks. These are the big ones. But if I look at something like Alberta Aids to Daily Living, okay, AADL is one of the programs, AADL grants. Now, I picked up the phone list, and it turns out that we can have mobility and large equipment. We can have hearing and communication. We have medical, surgical, prosthetics, orthotics, feeding, and footwear. There's 5 decision units right there. Without even going further, I could say, well, maybe with that particular one, how much of the AADL grants are actually going to prosthetics versus going to medical, mobility, and large equipment? That's it. That's all we're trying to do is get at least maybe one level below. Dental and optical. Dental and optical, we know there's seniors benefits. Are they the only ones who get dental and optical? Actually, no. We know that there's supplementary health benefits for others. So we may want to take it down one level below this, because on the health benefit side, we've already got 20 program areas identified. And all we're trying to do is to say, if we took it one level lower, it would give us a little bit more granularity in terms of determining what is the spend on aids for daily living in each of these areas, and how does that contribute to the outcomes we want to achieve. So that's an example on the benefits side. Okay, I just wanted to use it for grounding. Okay. Okay, so the question is, so why are we doing this? Okay, I mean, the question everybody's going to ask, so why are we trying to do this? The next step in the process is we're really trying to look at the relative importance of all of these services and programs that are being offered in terms of the degree to which they are contributing to the outcomes we've defined as important. So we've got this bubble diagram. We've got words like equity. We've got words like prevention, quality care. So in terms of some of the services we offer, are they making more or less of a contribution towards equity, quality of care, and so on? When we look at some of the programs that are offered, we're going to evaluate them across each of these different and say, how well is this program contributing to equity of service, contributing to quality of care, be it accessibility, appropriateness, safety, prevention. We've got one of the key areas is we want to focus on prevention, we want to focus on equity, we want to focus on quality care, which is things like access and so on. Are these programs making a difference in those areas? Are the programs we've got defined here actually contributing to better access? Are they contributing to better equity? Are they contributing to prevention, or are all of these reactive and not preventative? Because what's going to come out of this is if we say prevention is an important characteristic of the health system we want, and yet we find all of the programs and services are focused on reacting instead of preventing, it's going to come out and say what we say is important and what we're spending the money on is inconsistent. So either prevention is not a priority because the funding is all going towards reactive, or prevention is a priority and we need to reallocate some of the resources from these other activities to preventative. Well, which ones would we choose? Well, now if we look at all of those activities that we've identified and said which ones are making the best contribution to overall health and wellness, and which ones are making the least contribution, the ones that are making the least contribution candidates to maybe move to more preventative services. And now what we're starting to do is to say, how do we identify which programs and services are making the best contribution to things like access, appropriate, safety, prevention, and which ones are making the least contribution. In doing that, this helps to simply organize it. Now, the trick is, you're right, we can't go through every, I don't know how many physician codes there are, 3,000. We're not going to go, we do not have the time, we do not have the mandate to go through every physician code and figure out every one of them. But is there a level in terms of primary care that's a little more specific than primary care? I don't know. That's where we now are looking to you to say, here's the concept. Unlimited time, unlimited resources, sure, we do all 3,000. Doesn't make sense to do all 3,000, especially when they're mandated with the Canada Health Act. But we've got to get this, $1.4 billion spend broken. That's a boulder that we got to find a way to break that down into maybe a little bit more detail. And that's where we're going to look to you to say, how might we do that?
Actually, that's to be updated because we're taking a specialist from year 2 to year 1. The budget is more like 3.3 billion, and the 1.4 billion is professional practice.
Really?
It's not primary care network. Primary care network per capita is 180
million. Okay, so primary care. Okay, so if I look at Boulder, I may look at this and say addictions and mental health is 25 million. You know what? May not make a lot of sense to go much beyond that. It's a very targeted subpopulation, very specific needs. That one may be the right side. Don't. Oh, it's kind of a, okay. So that's one thing they'll say, fine, we don't need to do any more analysis on it. But if I look at primary care networks, what are the things that they do? And it's soup to nuts, we know that, but are there some logical groupings within the primary care network family of programs and services that we offer that are a level below the $180.8 million spend? Because there are elements, I would argue there are elements that are done within the primary care network that are contributing more or less value to these outcomes around prevention, equity, access. That may be, because this whole notion of programs and services can and does at times get skewed and overlapped. It may be the service bundle. So again, I don't pretend to understand what all of the elements of the primary care network are. That's what I would want to do. This is where John and Chris can say, oh, okay, now that we know what primary care network is intended to do, that's your collection of doctors that provide frontline service. What are the things that they do? Let's look at those service bundles and say, oh, okay. Because in looking at the service bundles, again, I look at prevention versus treatment. We say prevention is important. I'm going to guess that when we actually look at the total amount of dollars spent on prevention versus on treatment, I just have to look at the drug numbers, they're skewed. So how might we make a better, more informed decision? If prevention truly is an important outcome, we can't simply say, well, let's add another $100 billion to the budget. We have to say, well, where might we find dollars to reallocate to prevention? The only way we can do that is start looking at those services or service bundles that are not contributing to the things that we deem important. And that's what this process is trying to do. It's to try and give us a sense of what are the things that are contributing to better access, better equity, better quality, better prevention. These are the things that we've defined as what the health system is all about. We said that's our health system. That's what we want to be able to demonstrate that we are achieving.
Just a quick question. So once let's say we have numbers broken down, is there benchmarks out there that we can use to better streamline? Like, I don't know.
Potentially. Here's the question. Why do you want a benchmark?
I know if institution elsewhere might not work here, but for us to, I can really understand how to breaking down and the analysis, how we can find dollars elsewhere. Yeah, that makes
So
sense.
here's the next part of it. When you get to benchmarking, what do I want to benchmark? I want to benchmark. So we break these down. We get into the social quartile. The highest, the quartile one are the ones that are making the most significant contribution to what we deem as the important thing. Those are the ones I want to benchmark. I say, okay, those 20 programs out of the 200, I want to know how well I'm doing because now but I now pick a subset of the programs to benchmark and say, access. We can't have 6 months waiting. Our benchmark, we know best practices and we know we need to focus on better access, so let's benchmark.
Yeah, and then if I'm able to provide care at an earlier date, then hopefully I'm not needing to do more complex levels.
Right.
I'm trying to avoid or
You're trying to
focus
on treatment,
earlier treatment.
earlier intervention as opposed to late treatment. Diabetes being a prime example, fetal alcohol spectrum disorder, prime example, most preventable. And what's the cost of one child with FASD versus the prevention that happens, right? What this will show, though, is that the dollars that are currently being spent on prevention are probably, those have the highest value, perceived and or real value. When we actually combine and look at what is the spend on those relative to what the perceived, we're going to see the distance. We're going to start to see that although we say prevention is an important component, current spending is not aligned with what those high priority items are. So that's step one, is understanding where the dollars are going. Step two then is, so how do we reallocate dollars to be able, we say it's important, but we can't, let's assume the pie is only a finite pie. We can't add new dollars, we got to find the dollars somewhere else. So where are we going to find those dollars? Well, it's in the ones at the lowest quartile. Those are the ones that we've determined have little or no direct contribution to equity, prevention, and so on. Why are we doing that? Well, maybe it's because they're legislated.
And the whole benchmark issue is because essentially for the ones where I want to do, where I know there is better correlation, because fact of the matter is how this is always going to be qualitative. You can keep doing what you want, but it's going to be hard to come up with a perfect correlation equation.
Absolutely. No, we know that. And that's one of the things, one of the traps that people are falling into. Well, let's create the measures first for all the programs and then evaluate in terms of how well they're meeting their performance measures. You go, you don't have the time to create performance measures for every program that you're operating. There's a cost to do it. So then how do you pick the right ones to put in place performance? You pick the ones that are making the best contribution to the outcomes that you see important. And this is what the exercise is trying to do. One of the things that we talked about coming in is if we were to pick a couple of these program areas as candidates for further breakdown, help us pick the right ones. Obviously, addictions and mental health probably doesn't warrant a whole lot more conversation because it's a program that's relatively new. But I would look at primary care networks and say, that one, I want to look into a little more. Let's try and understand what the real purpose of a primary care network is and how do you measure whether it's being successful or not. Are the primary care networks being successful? Yeah. Sure.
Is it different than zero-based budgeting?
Absolutely. Absolutely.
It sounds, what you're talking about sounds exactly like what I've done with zero-based.
So zero base says all the money, we're starting from ground zero again.
Yeah.
Justify your program, but I do it one at a time, at a time, at a time. What this is trying to do is create relative value to achieve defined outcomes. Zero-based budgeting says you have a program, justify your program, and I'll give you dollars for your program this year. But next year, you got to come back and justify it again. It looks at them very much individually.
Could it be, for example, like a budget, right? And you have money for education. Try to see where can I.
How do I allocate against it? Well, you have a limited budget. How do I make the determining? If I determine that in my family, my children are the most important priority, then I'm going to shift dollars to those things that contribute to my kids being educated, healthy, and so on. Well, this is similar in many respects. Yeah.
of the reasons that we were suggested to have an evaluation person here was to make sure, though, at least in the process, that it's not going to tie the hands for an evaluation framework further to come.
Absolutely.
Correct? Have I got that correct?
Absolutely.
So at this point in time, no framework, no formal evaluation framework for each area, but using those generic overarching outcomes. Is that correct?
Absolutely. Because then we develop evaluation frameworks appropriately for the ones that make the best contribution, and we don't waste time building evaluation frameworks for things that have little or no value. Bill 1 says three things: relevancy, effectiveness, efficiency. This helps define relevancy. Relevancy towards the things that we've said are important. Step 1, if it's not relevant, why are we doing it? Once we've addressed the relevancy question, then we can say, is it effective? Is it achieving the goal? If we want healthy kids, are these programs resulting in healthy kids? We've got good evidence that immunizations reduce the incidence of people getting mumps and measles. Good causal relationship. So now we've got evidence to support that program A is contributing to a desired outcome. But we have other programs where we don't have that. We think that if we do this, we'll achieve that, but we don't have the performance measurement process in place to do that. Well, we don't have the luxury of doing that for all programs, but if we start at the top and say, these are the ones that have the highest degree of relevance, now let's start putting in place measures.
And just one more, that's right, but
Sure.
just one more point on that. So I understand about the full outcome and health evaluation framework, but using primary care networks as an example. So for instance, do they meet the needs of screening? Yes, I can say, I can give a subjective perspective. I believe they do. Okay. Or as you're talking, which an evaluation and having indicators and all those kinds of things, access. For instance. So do they need time to serve next available within X number of hours? So do you hear what I'm saying? That's where some of the measures.
Absolutely. And if they're there, let's use
utilize
those
them. Okay, so
to inform. No, if those measures exist, absolutely, as we do that evaluation, those help to inform and justify why I'm rating it as higher than those that I don't see the connection. Because we're trying to create a spread between those that are relevant and meeting the needs and those that aren't. And that's really what this is. How do you evaluate all of these programs with some degree of consistency in a, quite frankly, a ridiculously short window of time, yet still have something meaningful coming out the other end? These boulders are too big. One of our goals coming out of today is if we were to pick a number of these for further refinement, which ones would they be? Because you're the people who know many of these areas.
So saying that we could be different as a primary option. So because this perhaps the unlocking that, you know, as we've gotten to have more conversations with workshops, we better check that in specific areas to figure out who needs to go deeper or what. And so we want to start the conversation here. Our thought is that if we get back together and try to work through an example, something here that would make sense, that is a primer for that, and then we can bring that to the thing. You know, here's things that we don't like for that. Is there an ideal number?
Is there an ideal number?
Yeah. Like,
The short answer is it's all dependent upon the amount of time you have.
like you know what I mean, of design units,
Sure.
vision units.
Hundreds. But you've already said you've got 3,000 without even blinking. So, you know, that's the reality. We're talking about orders of magnitude. If we limit ourselves to the 20 plus the 10, we've got 30.
Those are individual categories.
Sure. And again, those can be rolled up, right?
Yeah.
Based on how much we spend. Like, I don't know if all the 3,000 even get used. If there's probably a few they don't
Some
get,
of them are
right? And then some are probably under cardiology or, like, you know, there are different ways you can group that. And then, so that's something that as a business, I think we have to come up with here on what we. So one last thing is the importance you talked about and the efficiency part. So the ones which you know are top
lives of Albertans. So let's know that first. Effectiveness implies an element of measurement. Effectiveness says, are we in fact able to prove that we are achieving the outcomes that we want to achieve? Every ministry is at a different point of evolution in terms of the degree to which they have the data to prove that they're achieving these outcomes. That's job two. Finally, efficiency is, if I can get $3 of output for every dollar I spend, that's great. If I can make 3.5, that's even better. So now I want to focus on those that I can actually streamline, look for ways of getting the same results with less dollars in. This process today, as Jennifer said, was to introduce the concept to say these may be the right size. We don't know. But what we want to do is have another get together. Now that we've introduced not only the concept, but the why behind the concept, to say this will help us in that relevancy assessment to say, are we in fact focusing our time, effort, and energy on the right things, given we keep saying this is what we want our healthcare system to look like.
From a product perspective, we've already done that with our AIDS addiction program. We've taken it and broken it down. Remember I gave you the example? Yeah. So we're probably already ahead of the game on the 1 year. That's been 1 year.
That may be a great one to use.
We've already done it.
Excellent.
Okay, so we've got that.
Okay.
But then take the primary care network one, which is much more complex.
Absolutely. I'd love to do that one.
Yeah, and then I think we need to take a look at that, because that could be fun, anyway, Sunday or however.
Exactly. But you know what?
Like we're all here, but
No. I would just as soon take that one and try it out. Because we may say, well, we could divide it this way, but we could divide it this way. Then I would go back to John and Chris and say, okay, John, Chris, primary care network is everything. So how might we come up with these reasonable sized decision units without getting into the detail, but more granular than just primary care network? That's too big. Because at the end of the day,
what I like to propose is, you know, this is a part of my work. We need to get on the same page that we're getting advice for. Again, one of the model is funding it. You get it very for the outcomes of here. And we here's what I propose. Have a look at what you've already given. Feed it back. We're going to close our loop. And what we wouldn't mind doing is connecting with you guys and say, we've taken that, tried to translate it here. Will that make sense? The resident, I think part of it is like, we don't want to come here and then say, those are our yeah. We're trying to figure it out with you. So then could be what I'd like to do, because we learn from that, get together with you and the three of us could get together and say, I don't know what. We'll learn. And I'm responding to that, and maybe there's an hour or two on Friday, and we can there's time to get. Let's try and translate what we've got. Way down 27th program, we try and figure out. You know, I rather hold my hand. I like them. Yeah,
What we do is again from our like dollars and those numbers, and they should put it on that spreadsheet.
perfect.
So,
We have 3 or 4, whatever the program is divided into.
Yeah.
We can do it.
So,
And that's.
and I consider these criteria, whatever you call them, see if I can somehow we can make them more consistent or at par.
Does it make sense though what we're trying to do? Okay, and again, you know, this is all we're trying to do today is introduce the concept. If you got that for the RIC, fabulous. Let's use that as a starting point. Then let's look at primary care networks and say, what did we learn? How might we apply it? Because again, our biggest enemy right now is time. And we just don't have the time to do it to this level. We're trying to give you, here's the ideal. Now, how do we adjust ideal for reality? And our reality is, we got this much time to do it.
This is the thing, you know, like looking back at the timeline, that's like, and this there. This is something that really needs to happen, and it's a month until Friday, you know, take a day. That's the important part, because before we go into stop this, right, we need to know, what kind of thing we can prepare it, so, which is the following. word is perfect, but we have the, you know, if we were going to, this part's gotta be done later.
Yeah.
My gut tells me.
Yeah.
So we're gonna have to go through this.
To build on what we've got, learn from that first exercise and one that's well defined, take it to one of the tougher ones. See, because if we get, you know, one that's done and one that's not been done, but it's one of the tougher nuts to crack, and we can say, you know what, it kind of worked. Now we, yeah.
I know I see exact sponsors.
Well, I have, much more to do. If you find that mobile and available, maybe tomorrow morning we can put this note together and.
So does it at least conceptually, you know, we're not, conceptually, does it make sense of why we want to go at least one layer down? You're still,
Not on the Canada Hospital.
and that's, no, on the insured services, exactly. We may say, you know what, everything to do with insured services, we're just taking that offline for now. There's nothing we can do, but just take those ones out for now. That's a separate, complete, nothing we can, your circle of influence, circle of control, there's nothing we can do to change that. So then let's look at the ones that aren't covered by the Canada Health Act and say, those are the ones we want to. So now we've got,
Like before the meeting go, what we should do is, sounds like it's okay that we start Friday. Yeah, because
we're not there
here,
till
we're chicken time.
so
Yeah, and we have, and maybe Monday, yep. And then later we need to marry those two, but I think that we can quite easily do it separate. Three chunks to divide this, the plan would be, but we need that more clarity by, say, Monday, Tuesday, on a good solid example of specific, and then we will have to how involved.
thank you all for coming. John, Chris, we'll do a bit of a debrief after, but thank you guys for that. I think we're moving the ball forward.
Thanks very much. No, it was a great session. We're off on the right foot here. So yeah, we'll look to hear from you. And thanks a lot, everybody.
Give me a call back later. Okay, thanks.